pressure on me. Well, no, that's true. You know, what you find out is lots of universities have these opportunities, and they're easy to take advantage of, and they want people. So it's one of the real nice perks that an academic life provides. And we met with my advisor, Bill Morgan, last night, and when I was in graduate school, he said, well, you know, you'll never make as much money as a banker, but an academic lifestyle is a great one. You get to travel, and that was before I'd done anything. So there certainly are these opportunities, and you'll see that as you move on in your careers. So I'm here to talk about something completely different today, and that's the placebo effect in exercise and sport. But I have to give you a little bit of a disclaimer here, is that I don't do any experimental placebo research. Not yet. The closest work I do to this, which I think is actually very related to placebos, is in pacing research, where we use deceptive paradigms to pace athletes at distances or intensities that they don't realize they're doing. So we manipulate their expectation that way. It's a phenomenon very related to placebo effects, but I won't be talking much about it today. My interest in placebo started in graduate school, but several years ago I had the opportunity to work with and meet Chris Beatty, who's really the leading sport placebo researcher in the world, and then Fabrizio Benedetti, who is probably the overall leading placebo researcher. So my work has been more theoretical, talking about the way research should be done, what a placebo effect actually is, and so on. So I'll be talking about that, but I'll also be talking about interesting ways of integrating the placebo effect and testing it in exercise and sport paradigms. And this goes way beyond the so-called double-blind paradigm. I'll be talking about examples of research and what we've learned about the placebo effect. So one thing about the placebo effect is it's been around for a long, long time. Here's a definition that comes nearly, 200 years ago, and it's very close to our conceptualizations of it today. So it's an epithet given to medicine, adapted more to please than to benefit the patient. And of course, a placebo, if you find the translation of it, is I will please. This is the classic definition that came from Beecher's paper, which really changed the way clinicians and researchers regarded the placebo. It was back in 1985. And again, it's very, very similar. Inert agents or procedures aimed at pleasing a patient rather than exhibiting a specific effect. Now, Beecher's study, which is really considered to be sort of the modern landmark, concluded that 35% of patients benefited from placebos. And at that point in time, people started saying, wow, they really work and they really are powerful. And for 15 or 20 years or so, maybe longer, that was sort of the way placebo was regarded. So its reputation improved. But then people went back in and started looking at what Beecher did, how we analyzed the data, and they started recasting these findings as what we call nonspecific effects. So regression toward the mean, natural variability, spontaneous remission, things that looked like the placebo was causing the improvement, but would have happened anyway. So then the reputation of the placebo sunk way back down again. And I always like finding these descriptions. A therapeutic dud, I think that's like the worst thing to say about anything. And then an imaginary improvement in performance, and that was the sports medicine definition. But what happened about 15 years ago is people started looking again at placebos in a very different way, primarily using as well brain imaging technology. And what they found was that placebos had very profound effects on the brain. I'll just summarize those briefly. But they started believing in placebos again, and the research was really rather compelling. And again, Fabrizio Benedetti, an Italian neurologist, has done a lot of the work, and I'll be talking about some of his sport-related studies. So what that has done is caused us to sort of recast the definition of the placebo while considering this evidence that says, you know, it really works, but how and why does it work? I don't like this definition, but I'm going to show it to you anyway because he's an important researcher. And you can see it enlarges these previous ways of describing the placebo. So it's a genuine psychological or physiological effect attributable to receiving a substance or undergoing a procedure. So they do separate, you might say, physical placebos, pills, other sorts of medications, fake medications, to psychological procedures. But it's not due to the inherent powers of the substance or the procedure. Here's a simpler definition, but one I want to expand upon because this starts to get into why placebos may actually work. So it's a simulated treatment, which which again may be psychological or physiological, and the surrounding psychosocial context on the patient, or in our case, on the athlete. So this is acknowledging that it's not just the substance or the procedure that you're administering to the patient that provides this powerful placebo effect. It's the situation and the social environment surrounding it. And so I'll expand on that in a little bit. Here's the definition I really hate. This is the standard sports medicine definition of the placebo: a favorable outcome arising purely from the belief that one has received a beneficial treatment. This, I think, constricts these sorts of definitions and the causes and procedures that contribute to a placebo. So one of the things I'm really trying to do is, in some of the papers we're writing now, is to update this definition. Because sometimes you don't even have to believe in a placebo for it to work, and sometimes you don't even have to know what it's supposed to do. So without getting into the detail of this, because this is something I really can't get into, what I want to emphasize is that the placebo effect is not an effect. It's really placebo effects, because what you're administering and what you're administering the placebo for have different physiological and neurological consequences. So there's been research that shows that placebos influence immunological function, hormonal responses, depression, Parkinson's disease through dopaminergic pathways, hyperalgia, analgesia, and analgesia using either opioid or beta-adrenergic nociceptive effects. So in other words, placebos affect different bodily and neurological pathways. There are lots of different placebo effects. The two main mechanisms by which these effects are supposed to be exerted, I'm simplifying here, is through conditioning and expectation. And I'll talk about both of these in the context of some sport research later on. Sometimes I think it's difficult to distinguish between the two. So when you're conditioning people for placebo effects, their expectations about the outcome and how much they'll benefit may also change as a result of that conditioning. But those are the standard sorts of definitions. Now, placebo effects are typically described in terms of giving an inert or a fake agent. But one thing to emphasize is that real medicines, real interventions, part of their effect is also due to the placebo. So in other words, placebos contribute to medicines that we know work. And these are several examples, all involving painkillers, nociceptive types of, so morphine, Tramadol, and so on. And what we see is that when you administer these medications, when the patient knows about it, and these are all patients with clinical pain, and the way they do this is they have IV drips that there's a light that switches on. So they know when they're getting the medication, and then they rate their pain. They see greater relief than when they're getting the medication, but that light doesn't go on. So in other words, they aren't sure whether they're getting it or not, and then randomly they assess their pain. There's a significant diminution in the benefit. So in other words, awareness of medication, the expectation of benefit can sort of prompt a placebo effect or an additional benefit in the case of medicines that really do work. So placebos are often looked at in both contexts. My interest in the placebo, one of them, is that there's very similar context between sport and patients. And the majority of placebo research obviously involves patients and medications. But then we have these placebo effects that benefit athletes. And you think, that's kind of peculiar, because what placebos do for patients is they relieve conditions and reduce symptoms. In other words, they sort of bring them a little back toward normal. In a way, you can think about that as being baseline. That's probably one of the reasons why we see these non-specific effects, because people tend to get a little bit better anyway. In the case of sport, it's exactly the opposite. We're shoving them away from baseline. Placebos work is because it's driving them higher toward that performance ceiling that they're already bumping against. So you're not going to see regression effects, improve performance. That's exactly the opposite. Nonetheless, they work for super healthy people as well as people who are not healthy. What we know, and this is an adaptation from Benedetti's work, but this is my friend Chris Beatty, and I was at a conference with him, so I was trying to make fun of him when I did this. But this is the psychosocial context when we talk about patients. So patients have personal beliefs and expectations about medications that may not be the medication they're getting, but the fact that they've got medications in the past. They have memories about previous therapies and the outcomes associated with those therapies. Then you have the side of health professionals, hospitals, and medical instruments, so that's part of the psychosocial environment. There's interaction with patients and people. There's being touched by the physician or by instruments. That's a very profound contributing to the placebo effect. There's the physical characteristics of the placebo. We know that certain colors of placebos are more effective for certain conditions. We know that capsules work better than tablets, and injections work better than either of the two. So the physical nature of the placebo can, in some cases, amplify its effect. And then, of course, there's what the doctor is saying. Well, we can recontextualize this in sport, and you see exactly the same thing. So you have memories about previous events and ergogenic aids, which are very popular among athletes. You have personal beliefs and expectations about what those will do for you. You've got the side of the coach, maybe a psychologist, the crowd, so there's that. You have an interaction, social interaction with teammates in the audience. That can certainly affect it. You have a lot of physical touch by needles, tape, hot and cold, all sorts of things. Even, I think, more than what you see in medicine. You have the physical characteristics of the ergogenic aids, the color, the taste. This is an interesting one. I learned this from Pat O'Connor. That 8-hour energy. They put niacin in there because if you have a certain genetic variation, you feel it. It tingles, and people interpret that as energy. You ever experience that? Yeah, there's this tingling sensation. So it must be working. Yeah, it's not inert. It's doing something. And then you have the words by the coach, trainers, and fans. If I have time, I'll finish with a story, which I think is the most remarkable sport placebo story I ever heard with a very good athlete. And so the psychosocial context matters. I do also want to talk about the placebo's evil twin, and that's the nocebo. How many of you have heard of nocebos? Okay, a few of you. So nocebo is exactly the opposite. It means I will harm. So in other words, if you administer an inert agent with expectations or information that's going to make you feel more anxious, more fatigued, going to keep you awake, agitate you, it will, more often than not. And so the definition of the nocebo effect is an induction of a nocebo process represents a stressful and anxiogenic procedure. The sports medicine definition, again, drives me nuts. It's, I think, misleading. So the idea that a control group becomes a nocebo. In certain exercise and sport paradigms, I agree. In other words, if one group of athletes is training and you're in the control group and you're not training, well, certainly your expectations for that outcome are negative. But for instance, in altitude studies, if you're training at altitude and you have another group of athletes doing control training at sea level, if those athletes don't like training at altitude or have had bad experiences with it, that's not necessarily a nocebo, even though technically that's a control group. So this definition, I think, loses the intent of what nocebo effects are. I remember Dr. Morgan's here. He told us that in one of his book chapters that it's very difficult to improve performance by using hypnotic suggestions of improved performance. They're at the ceiling, but if you tell them that they'll get worse, then it always works. And so it's like you've got to hypnotize your opponents and make them think they're going to do poorly. Not easily achieved. This is, I think, the best recent example I've seen of the nocebo effect. So that's Shawnee, I forget his last name, one of our best speed skaters at one of the previous Olympics, and he had that brand new, very expensive Under Armour, I think that's the brand, speed suit, and he did terrible in his first race. And he started panicking, and he refused to wear it for the fall-up races. And then the rest of the team ditched their suits, and they were calling back home to get their old speed suits. And so they asked the Dutch coach, and they won all the medals except for one. 21 out of 22 gold medals about that suit. And he said, why did the Americans do poorly? And the suit was one of the reasons, but not because it was bad, it was because they believed it was bad. So for me, that's exactly what a nocebo effect is. These suits may not have been harmful, they probably weren't, but once they thought they were, then their behavior matched their expectations. This is another placebo device, at least the way it's used. Do your basketball players wear these? Oh yeah, all the Hooters do. Yeah, that explains a lot. Anyway, it's very popular with pro players wear. So they call these altitude training masks. That's not what they do. They don't mimic altitude. They actually increase inspiratory resistance. They train your diaphragmatic muscles. Dr. Dempsey's work here, 20 years or so, really was the work that led to this. But this is always interpreted as, oh, it's high altitude training, and that's what the athletes believe until they wear these, even if they aren't training, they think, oh, I'm walking around, it's what they say, 3,000, 6,000, 9,000 feet of altitude, by putting in greater resistance. So this to me is like, they could work if they were used right, but this is basically a placebo effect. Why does it work? Well, remember the physical characteristics of these. Here's why I think these things work. Because they look really, they look like Bane. Yeah, I mean it. I fully believe that they, modeled it after Batman's nemesis there. Anyway, so if you're interested in placebos in sport, there's all this really wacky, cool stuff that you can immerse yourself in. I will say sometimes what we think is a placebo effect in sport or interpreted is this, which I think is the most boring version of the placebo. So a lot of people say placebos work simply because they make you try harder than you would have otherwise. And sometimes that happens, but not always. And here's an example of this study where this is exactly what occurred. So they were putting swimmers at time trials at different intensities and measuring standard physiological responses with or without a fast suit. What they found was that they went faster in a fast suit. Now, if there are any of you out there interested in sport performance, this 2% is always the magic number. Because if you get maximal performance in athletes and you do sorts of interventions, like some of our interventions where we manipulate pace, you can bump them up about 2%. And that's about it. So this for me is like, the standard 2% improvement. But what they found was that they were simply working harder. So there were greater physiological responses for all of these factors. And the researchers interpreted this as that they expected to do better, so they simply tried harder. Sometimes placebo effects work without changing these sorts of variables. So we don't see increases in lactate, increases in oxygen consumption. So that's like, what's going on then? It must be a different mechanism. Well, this study had lots of problems, and if you do this sorts of research, everybody does RPE. And the problem is that they often just get RPE at the end of things, when everybody is at their peak. And if you're going to figure things out here, or sort of learn about why placebos may be working, you've got to really look at growth curves, because it may be early in these sorts of workouts that you're going to see, the intervention having some sort of effect here. The other thing I will say is that a lot of placebo sport researchers outside of sports sciences interpret perception of effort as a measure of fatigue, and it's not. There's an aspect of fatigue and perception of effort, but it's not the same thing. And if you do that, if you conflate the two, I think you're losing out on potentially useful information. As some people say, the perception of exertion is not the same as perception of effort. So I think there's some subtle things going on which may be lost in this sort of research. Well, how do you do placebo research? It's the randomized controlled trial. You know what that is. So you blind everybody. You have experimenters are not supposed to know what they're giving the patient or the participant. And then you have participants that don't know what they're getting. And this is considered to be the gold standard, and that's the way placebo research is typically done. The challenge with this is that it's a good paradigm, but you're missing out certain sorts of information. The other thing, of course, is that in a clinical setting, the person getting the medication knows that they're getting medication. In this case, they know that there's a 50-50 chance that they're getting medication. And I'm going to show you some examples later on in placebo research where they manipulate the odds that you're getting medication or not. And that sometimes changes the outcome. And so, the randomized controlled trial isn't new. Maybe the earliest version of this is when Benjamin Franklin was assigned by King Louis XVI, I think, to investigate mesmerism or animal magnetism. And he and the chemist Lavoisier, if I'm pronouncing his name right, conducted essentially what were double-blind tests. They called them trick trials. And so they had patients touch supposedly magnetized objects to see whether they exhibited this effect, and nobody knew what they were doing. And Franklin, in his description, really was described the placebo effect, the spirits given by the hope of success, in other words, the expectation, relief from whatever their treatments, and the electrical shocks for the treatment enabled them to exert more strength in moving their limbs. So that is a pretty fair description of the placebo effect that they were testing back then, and they debunked this. So this photograph shows Raglin routs the mesmerists, and there he is holding up, I don't know what. Science wins. Back then. Well, another aspect of the randomized controlled trial is that when you see a benefit of a placebo in the placebo condition and a benefit of the treatment, it's often regarded then you can put the two together. In other words, 20% improvement with treatment, 20% improvement with placebo, then you've got 40% overall improvement. Often that's not the case. You have an interactive effect where there's some sort of an overlap. And this slide doesn't display it very easily or adequately, but sometimes you'll see a lower net benefit. So there's some sort of subtle interactions between the placebo mechanism and the treatment mechanism, and the overall net effect is different. So I think that's a subtle thing, but it's important to consider. There we go. Now, let me talk about an interesting design that's used in a lot of placebo research that reveals some additional information. It's called the balanced placebo design. And you have 4 treatments. So in one treatment, you're giving them the medication or drug, but not blindly. You're telling them that they are getting the medication and they know what it's supposed to do. This is equivalent to a clinical trial where you're getting the medication, it's targeting your condition, and you know what it's supposed to do. Here's the condition where you give them a drug and you tell them it's a drug and placebo only. Tell no treatment, but you get the drug, and then tell no treatment, you get no treatment. So here, this mimics real drug administration. This quantifies the placebo effect since they're getting placebo, but they're telling them it's the drug, so they're getting the expectation of benefit. In other words, it's not 50-50, you're getting the drug, but they aren't. This is supposed to quantify the pharmacological contribution because you're giving them the real treatment, you're subtracting out the expectation that it's real. So they think it's fake, and so if it works solely because of the biological mechanism associated with the treatment. And here's your control. So this is I wouldn't say an expansion of the double blind, but it allows you to kind of find out what the drug is really going to do or probably really do in an actual or clinical setting. I'm not going to go into these because I'll describe some examples of these, but there are lots of other variations of methodologies and procedures that can be used to test placebos. So one of them is open label. An open label is when you tell the individual that they're actually getting a placebo when they are, but you also tell them, at least in some open label research, that we know that placebos can work. And here's how they work. And there's research that shows it might work for this condition. And in certain cases when you do that, they work. Irritable bowel syndrome, asthma are 2 conditions that often benefit even though they know they're getting placebos. And some of these people, when they run out of placebos, they ask to get more. And they say, we can't give you more. And they say, well, where can I go buy placebos? That's all. You can do treatment-naive participants who don't know or have expectations. That's not often done. You can have placebos that have active side effects to more fully mimic what they'd be getting in the treatment condition. We'll talk about caffeine later on because it's often thought you can't blind patients to caffeine or athletes to caffeine because the side effects are so pronounced. I now don't think that, and I'll show you why. If you have an extended trial duration, typically placebos don't last. Their effect doesn't last as long as medication, so that's one way of watching the effects. You can have run-in trials where you look at strong placebo responders and you exclude them. Or, in a study I'll show you later on, you examine them in particular. So it's like, oh, these are the big placebo responders, let's see what happens to them. You can condition them. I'll show you a couple examples of that where you're actually giving them the medication, condition them to the placebo effect, or you condition them with false feedback where they're led to believe that the placebo is working, and then you can grade their expectations. So I'm going to show you some sport examples with each of these. And we'll use the example of caffeine. Caffeine is the most widely tested ergogenic aid in sport. So you know what that is? That's the pattern. I don't know which ones are carbon and hydrogen, but anyway. So here's some example of Beatty's work involving a placebo caffeine. And they looked at cycling performance. And so here, they don't think they're getting caffeine. There's a small decrease. He would regard that as a non-significant nocebo effect, but you'd have to compare that to a control condition. Here think they're getting a low dose of caffeine. Again, it's a placebo. We see significant improvement, and they think they're getting a high dose. So there's this graded improvement based on how much caffeine they're getting, even though that both conditions are placebo. So you can alter their belief about you getting 2 pills or 3 pills. In some cases, you see a greater placebo response. Here's another example where they're doing repeated cycling trials. 2 groups, no intervention, and in this case, they're given a placebo, and they said it's going to help, and they see an improvement. Here, they're giving a nocebo that they say it's going to make them worse, and they believe that that was a nocebo effect, that they continue to get worse. But if you look at this, of course, the other thing is what you need is a no treatment control, because they're getting a little bit more tired as the trials progress, and maybe this is what would have happened anyway. So again, it shows you that in a lot of this research, you can't just use a placebo. You need no treatment controls to look at this variability, and so you can find out whether it's natural variability or it's something related to the placebo intervention. But in his case, he's saying these placebos are starting to work. And here's a nice example from his research. So again, this is placebo caffeine with cyclists doing trials. So they're telling this is caffeine, and they receive caffeine, pretty big improvement in power. Telling them no treatment, but they're actually getting the caffeine, it works, not as much. Here's telling them it's caffeine, but it's actually placebo, so it looks like it's working equally well here. And then they're getting no treatment, and they drop down a little bit. So it looks here that this is perfectly additive. You add these 2 together, and you're getting this full benefit here. So the information you're giving these individuals, in the case of the placebo or the treatment, seems to influence their performance. It's not as effective. They don't know that they're getting it. But I'll show you another case where something different was found. I will say that in this particular study, they identified high and low placebo responders, and they limited their findings to the strong placebo responders. And that's one of the challenges of this research, is that people respond very, very differently to placebos. You have people who are naturally strong responders for very different reasons. Some of these reasons may be related to intrinsic psychological factors. Some of the reasons may be based upon their expectation and experience and past experience. And if you don't find out about that, then you may not realize that these are strong responders until too late. You also have weak and non-responders. One of the interesting things here is sometimes you can train them to become better placebo responders, but there's at least some research that's attributing this to, again, intrinsic psychological factors. There's also some research that suggests that there are genetic differences, and they link those to dopamine. And then you have negative responders who, paradoxically, if you give them a placebo that's supposed to improve their performance, they get worse. And then you have nocebo responders who just interpret the placebo negatively. So there's a lot of inter-individual variability in placebo studies based upon the fact that not everybody responds the same way. And you can either ignore that, or you can try to learn about that beforehand. And right now, for instance, Dr. Lindheimer and I, among others, are interested in the exercise placebo effect. We're trying to develop an exercise expectations questionnaire that will give us an idea whether people going into an exercise setting expect to get psychological benefits out of it or not. So we know beforehand, how they think that they're going to respond. And there's a lot of need for that sort of research. So I want to share a few examples of some, I think, interesting, also problematic placebo designs to look at sport-related or performance-related outcomes. And this was a study by Benedetti, who made some interesting ethical implications of this. So they used tonic arm ischemia to produce pain. And they basically conditioned these individuals with morphine. So let me go through this. I always get mixed up these designs. So we have a no treatment where they tested them under baseline. They tested them again, nothing. They had their competition because they were arranged in teams. And then they did them a week later, and there was no changes all along there. So the control was very, very steady. The second group, things get a little bit interesting. Let's see. It's the team A. I have to look at this carefully because this is so small. No treatment. Oh, here we go. B. I'm sorry. No treatment. No treatment. No treatment. Then they got morphine placebo. So they got an injection in the competition day. And what they found, without any preconditioning, there was a significant improvement in the duration of taking the pain. So the first time they administered placebo, it worked. And it worked significantly well. Now things get interesting because now they get no treatment in this group. Morphine, actual morphine, placebo, and no treatment. And what happened with this group was the improvement in competition was bigger. Even though in the competition they went back to a placebo. So in other words, if they give them the drug several times, and then they give them a placebo and say it's the same drug, it potentiates the placebo response. They're literally conditioning them to have a greater placebo response. And in this group, they did the same thing. No treatment, morphine, but the injection in the competition setting was naloxone, and it completely eliminated the placebo response. So they attributed the placebo response to a potentiation of the opioid pathways. So this study suggests that what you could actually do is train athletes on illegal drugs. At the competition, give them a placebo illegal drug, and they'll get a really big benefit out of it. So is that ethical or not? So it's not cheating technically, but if you're training athletes to respond to illegal drug placebos, is that a good thing or not? But it's an interesting design, and it gets into these sort of conditioning paradigms where you're actually giving them the medication several times, and what you typically see is a greater placebo response after the fact. So the pharmacological conditioning increased the response to placebo morphine. Unconditioned placebo morphine also resulted in a significant smaller increase in pain tolerance, as we'd expect, and you could completely reverse that through naloxone. All right, another one of these complicated designs. I have to look at this because every time, here we go. In standard double-blind condition, there's a 50-50 chance that you're getting either the real drug or a placebo. What they did in this case is manipulate the chances, and what they did is say, we're going to give you caffeine, and we're either going to give you the actual caffeine, we're going to give you 2 cups, and you choose, so there's a 50-50 chance that you're going to get the caffeine, or you're going to get 4 cups, so now you have a 25% chance, and you choose, or else we're just going to give you some placebo coffee, no caffeine. So here they thought they were getting it. Here they thought there's a 50% chance they're getting it. Here they thought there's a 25% chance they're getting it. Here they thought there was a 0% chance. But placebo, everything was a placebo. So you're manipulating their belief in it. Am I getting it or not? What they found is that when they were told there was a 100% chance, but this is a placebo, 50% chance, or 25% chance, the placebo still worked. It seemed to work to a greater effect. You can debate this or not. They thought these were significant, this wasn't. In other words, the higher the chances, the more the benefit, but not much more. In the case where they knew they weren't getting it, they got nothing, or they were getting what they were told was decaffeinated coffee didn't work. What they did then was they conditioned this. So they brought them back in under the same conditions. Let's see, nothing, 50%, 25, well, let's see, I have to look at this. Let me just show you the results. What they did here was they conditioned them, and did I show you what the strength training was in here? I did not. I can't back up. Well, anyway, it was a 60% weight leg extension, how many reps you could do. I forgot to mention that. What they do here is, this is an interesting paradigm. They give you the placebo, and they have you do the same thing, but they lower the resistance without you knowing it. In other words, the placebo really seems to work, but it works because you're lifting less weight, but you don't know that. But your perception is, oh, wow, this stuff really works. And they did that twice. So this is a different form of conditioning. They're actually, instead of conditioning you to the real drug, they're conditioning you to placebo, but the outcome is positive because their performance is obviously increasing in these 45% lifts instead of these 60% lifts. So does that make sense? Yeah. So you have to trick them in this case. What happens is they go back to the 60% here, and they give them the placebo, and they see, well, this is they know they're getting the caffeine, 50% chance, 25% chance, all of these are equal. So how do they explain this? Here's their findings. This is the way they explain this. Am I going backwards again? No. I hope. Oops, this is going backwards. Give me a second. No, let's do it this way. So high verbal suggestions, 50%, 100% can work alone. Low verbal suggestions, 25% work after conditioning. But once you condition them, that's what worked. In other words, their expectations were trumped by the conditioning. The conditioning is what led to the equal changes. So in other words, conditioning exerts one effect, expectations exert another, but if you train them through conditioning, then that's the only thing that matters here. So this is, I'm not sure whether I entirely agree with what they found, but it's a totally different way of kind of looking at this. All right, a related study. So these same researchers had 21 males. They did the same sort of strength test, total number of leg extensions at 60% max until failure. Strength test with no treatment, control, or placebo. So there it is. What they found was that the placebo worked, 12% improvement. Then what do? They came back in and they did this surreptitious change, 45%, 45%, so 2 conditioning trials, and then back to 60% chance. And what they found was that by doing this, under the placebo condition, they got a greater improvement. So their interpretation, and RPE was different, so let's read their interpretation. So they suggested that there's a strong top-down mechanism. In other words, you can change expectations. By changing expectations, by making them think that the placebo worked compared to this control, that their performance would improve. So there's these ways in these experimental designs of manipulating the effect of placebo through conditioning, manipulating the effect through altering expectations that will have income on the influence their outcomes. Okay, last placebo caffeine study, and then I'm going to turn to exercise because I'm getting a little jittery talking about this. This was a different sort of design. Again, I think it's problematic, but they had 42 trained cyclists do a 30-minute time trial. They did under control condition, established their maximum, and then they had them do it again under an hour following ingestion of caffeine. And after they got the caffeine, they themselves identified whether they thought they got caffeine or coffee. So in other words, did you think you got the real treatment or not, or are you unsure? So this is another way of looking at expectations. So in the previous studies, they manipulated that. There's 25% chance or a 50% chance you think you're getting it, or you are getting this. Here they're saying, what do you think you got? So instead of manipulating it, it's sort of like a natural trial. And so they drank the caffeine, they asked them what they thought they got, they tested them, and they asked them after the test, well, do you still think it was caffeine, or do you think it was a placebo, or do you want to change your mind? And they looked at the performances here. All right. This, again, is a little complicated, partly because they didn't find what they expected to. So this is caffeine versus the control. And when they were correct in saying, yeah, I think I got caffeine, and that's what they got, there's an improvement both before the test and after the test. So yeah, it worked. And when they were wrong, they got the placebo, but they thought it was caffeine. Look, it worked. And it kind of works here. Oddly, and this goes against what we'd expect, when they got the caffeine, but they said, I don't know whether I got it or not. That should have worked. That's what we consider the pharmacological effect. And it didn't. They were no better than control, and they couldn't explain this. But what it does show, it's like, wow, their beliefs are influencing their performance. Now, in the case of the placebo, they said, oh, it's a placebo and I got a placebo. Their performance is actually a little bit below control, and they said, oh, that's a nocebo effect. But I don't know. Is that significant? No, it wasn't. It approached significance. If they didn't know, there wasn't much of an influence, but if they thought they were getting caffeine and getting the placebo, you can see it's starting to bump up a little bit. So this is a totally different way of looking at expectations where you don't tell them or manipulate their expectations. You simply find out what they think that they're getting. Now, for me, there was another part of this study that was interesting. It was the amount of uncertainty here. Because caffeine is thought to be a difficult to blind intervention. You take it, you know you're getting that caffeine buzz, there's symptoms of it, so you can't blind people to it. But in this case, there was a lot of confusion. So this is a graph that I came up with just so I could kind of figure this out, to see how many people were right or wrong. So remember, they got the caffeine, and before they wrote, they said, what do you think you got? 40% of them were correct. 31 said, I can't tell whether I'm getting caffeine or not, even though they had caffeine. And 30% roughly said, no, I didn't get it. Then after the fact, you think, well, after the race, they should be able to figure it out. But even some of the people who got caffeine said, now I don't know. And now I didn't get it. And you can see, well, now I think that I did. And so they're all over the map. There's a lot of uncertainty here. So there were, and 6 people after the fact said yes, and they were correct. They, in other words, they were wrong and they changed their mind and they were right. But 8 people went from right to wrong. In the placebo, you can see there's an equal amount of confusion. 40% thought they got it. 40% weren't sure. 19% thought that they got caffeine when they're getting the placebo. And again, all over the place. So for me, I don't think this necessarily is a strength of the study, but it does reveal the fact that you can give placebo and caffeine and blind people too, because a lot of people really don't have any idea, and whether they think they're getting it or not getting it again influences their performance. So these sort of designs, I think, have not really uncovered the true effect of caffeine and placebo caffeine, but they give us some interesting ways of manipulating factors that we know in placebo effects and moving toward resolving this type of issue. I think it all comes down to these individual differences, though. All right, so those are their conclusions, and I won't go through these, but their final conclusion was that supplement identification appeared to influence exercise outcome and may be a source of bias in sports nutrition. And I think this all comes down to the idea, I think that I got it, or I think this is going to work. So expectation being a driving factor in whether these things work or not. So let's talk a little bit about placebo effect in exercise. And Jake's here so he can help unconfuse me on some of the things that I may be getting wrong here. But the placebo effect is thought to be a factor in exercise and mental health. Depression and anxiety are very responsive to placebo medication, these two sides. So we know that medication that really works has also a strong placebo effect. And placebo medications can benefit depression and anxiety. So why wouldn't exercise be different? Because there's a lot of research that shows that the antidepressant effects of exercise rival those of medication, and nearly so in the case of anxiety. So exercises exert strong effects. And if you look at that, 45% of physicians report using placebo effects in clinical practice. 45% of Americans engage in regular exercise. I don't know. And then, 45% of Americans use prayer for health. So maybe just chance. Who knows? But Dr. Lindheimer and his colleagues did a study looking at exercise mental health benefits or effects, comparing it to placebo conditions. And it turns out when you do this, there are not very many examples, are there?
No.
Yeah.
No.
And you need a control group to really parse this out. So let me show you what he found, because I think it's interesting. But one of the problems with this can you create an exercise placebo? In other words, can you blind people into thinking that they're doing exercise when they're not really doing exercise? And so there are people that make the argument you can't even do exercise placebos because there is no substitute. And so some people use rest, passive activity, low intense stretching. The list is longer than this, but you can make arguments for or against these. If I had to come up with one that I think would be closest, it's one of these things. Have you seen these? I mean, you stand on them and they vibrate. They do cause co-contraction. So there is some muscular activity, but you aren't moving or doing anything. But these are marketed as exercise types of devices. And I think they probably have some therapeutic use. But so to do this research, not only do you have to have a control group, you have to think very, very hard how you're going to come up with a placebo form of exercise. And people have tried. Well, what is this found? And I'm not going to go into the details of this because you'll correct me in all the things that I'm getting wrong. I've already gotten enough wrong already with these vexing studies, but there are lots of psychological outcomes that you could look at. The observed exercise effect period was, the effect size was 0.37. The placebo effect contributed 0.2 to that, which means the real exercise effect was 0.7 to that. So you divide one by the other, and it suggests in this limited number of studies that the placebo contributes about half of the psychological benefits that we see associated with exercise. And you may say, oh, darn, you mean that? But for me, it's like, well, that makes perfect sense because there are certain medications that the placebo effect is nearly 50% of the benefit. So why should exercise be any different? The other thing about this that you shouldn't interpret badly is, well, wait a minute. If expectations matter and they contribute so much, then we can design exercise programs that emphasize those benefits, that try to create those expectations of positive outcomes in people. And if you do that, and you do that successfully, then you can fully expect to see greater benefits. And I think that's not only desirable, that's ethical. So there is this idea now that physicians should build in, I guess not what you want to call placebo effects into their practice, but create that psychosocial environment through their language, through communication, through their interaction, through their emotional interaction with patients that could potentially benefit or add to all the therapeutic benefits that they provide. And Franklin said this a long time ago. So he said on hypochondria, he said, if these people can be persuaded to forbear their drugs, not the medications, in expectation, there's that word again, of being cured by the physician's finger or iron rod, those are placebo effects, pointing at them, then they may possibly find good effects, though they may mistake the cause. So this is exactly what I think he's saying here is, there is this therapeutic benefit here for people, in this case, who don't have a disorder but think they do. If they think that they're getting a treatment, they may actually get something out of it, even though that they think the cause or benefit of the treatment is through, what the physician is doing, where in reality is the placebo effect. So there is this, at least in the case of clinical practice, this idea is that, placebo effects, we want to cull them out of experimental trials so we can look at the true therapeutic or intervention benefit. But in the case of clinical practice, you want to cultivate those because it means that whatever you're doing for these patients could be made even better through exploiting the placebo. So, I'm going to close. I'm going to be right on time again. Look what time it is. The placebo effect in sport, it's long intrigued me. And for a long time, people thought, if you're going to get a placebo effect as an athlete, you can't be that good of an athlete. Well, let me tell you about an athlete who's really good, who had a placebo effect. And that was Mark Spitz. So he swam at Indiana University. When I first started at IU, I got to work with Doc Calzman, who was his head coach. And Mark won 7 gold medals. So he's the best athlete in the world records in all 7 events. And he was at a meet, though. This was a national meet where in his preliminary trials, he won all of them. So he's going into the finals being seeded first in every single event. But in his last prelim, which he won, he got out of the pool, and he's walking over to Doc, and he's shaking his head like this. He looked like he lost the race. And Doc went up to him and said, Mark, what's the problem with you? You just won that race again. You're going in the finals in first place. This is fantastic. He said, no, Doc, it's a disaster. It's going to be a disaster. Doc said, what are you talking about? He said, well, look, I already shaved and I already tapered, and I peaked in all the prelims. So in other words, he did all his interventions, and he was going to go downhill. That's what he believed. He peaked too early. And Doc knew that if Mark believed this is exactly what was going to happen. So his 2 treatments he'd already availed himself to. And you know what shaving does. All the exposed hair is supposed to improve lower your resistance. And Doc said, well, no, Mark, there's one thing we can do. We have to keep quiet about this. The East Germans have discovered that even after you shave, there's a rough layer on the top of the epidermis of the skin, so you can take very fine grit sandpaper and rub it down and rub that right off so the skin is even smoother. So go to the locker room And keep quiet about this though. So Mark goes into the locker room. Doc has one of the players go to Ben Franklin. They buy 800 grit sandpaper, and he rubs them all over with this. And he said, now keep quiet about this because if they find out about it, they may make it illegal. We're never going to do it again, just this one time. Okay, Doc, okay. So he goes in the finals. He wins all of his prelims, all the finals, more records. It worked. Now, sandpaper effect real? No. It was something that Doc made up on the spot. But he knew that Mark's beliefs and expectations would rule the day, and if he thought he was going to do worse, he actually would. So there are cases, I think maybe ethical cases, where coaches can and have to use these sorts of placebo procedures to do this. And I told my friend Chris Beatty about this. He says, oh yeah. He said, he talked about another famous British coach who was really good. He said, these guys are human placebos. Human placebos, because everything they do works for their athletes and create these expectations for success. It's like, that's the way they are. They just have this sort of magic about them. So